Okay, good afternoon, everybody, and welcome at the next Iran Reconnect webinar. My name is Maarten Limper. I'm a clinical immunologist working in the Netherlands, and I'm the disease coordinator of SLE for Iran Reconnect. We have a very interesting topic today, as always, but this one I think is really interesting for all clinicians involved, thrombocytopenia in lupus. I think most people recognize this as a very common phenomenon that sometimes does not treatment, sometimes is very severe. There's a differential diagnosis in between. So I think a lot of questions and hopefully a lot of answers for us today in this webinar. And I'm very happy that we again have two excellent speakers to guide us through this subject. I will shortly introduce both of them to you. Our first speaker is Hilde Kooistra. She works as a hematologist in Groningen, in the upper north of the Netherlands, in the academic hospital there. She did her PhD in 2016 on anticoagulation and vitamin K antagonists, and she's a clinical epidemiologist as well. And she has been working in Groningen for 3 years now, ever since 2022. And our other speaker today is Karina de Leeuw, who is an internist clinical immunologist, also in Groningen in the academic center, with a PhD in 2008 on cardiovascular disease in lupus as well as in vasculitis, and registered as a clinical immunologist since 2015, and from that moment on working in Groningen. And together, Hilde and Karina take care of a lot of lupus patients, including patients with thrombocytopenia, and I think they are the clinical experts to guide us through this subject. So I will leave the floor, the online floor, to them. There will be ample place for questions on the end. We will take until about 4:45. So please feel free to post your questions either through the Q&A live or in the chat, and we will discuss them at the end of the talk. But for now, Hilde, Karina, please, the floor is yours.
Yes, thank you, Maarten. Well, here we have the content of our presentation. First, I will begin with the definitions of ITP and SLE, and I will introduce two patients to you. And of course, well, we are going to discuss their diagnosis and also their treatment. But first, Hilde is going to tell us about differential diagnosis and also the pathogenesis of ITP, and she will give well, guidance for the treatment for the thrombocytopenia. And after that, I will come back to the patients I introduced before. So, like I said, first, the definition. We are talking about immune thrombocytopenia. And well, if you're looking in the literature, it's defined as thrombocytes less than 100. And when you're talking about immune thrombocytopenia, well, you have to exclude first other causes of thrombocytopenia, like, for example, bone marrow disorders or medication or liver diseases. And when there is no other cause of thrombocytopenia, you can think of the immune thrombocytopenia, so the ITP. And well, when you have the diagnosis of ITP, then the next step is to make the difference between primary versus secondary ITP. Well, and primary is if you cannot find any other causes, and secondary if it's secondary to, well, all kind of situations like autoimmune diseases, but also immune deficiency, infections, or medication. If we look for the primary thrombocytopenia, the incidence is around 3.3 per 100,000 persons, and it especially affects young women. Well, sometimes it can be asymptomatic, and it's well, it is found when blood is taken, and it's around 20 to 33% that it's asymptomatic. But it can also be with symptoms. And what do the patients complain then? Well, they can have problems of bleeding. Often the thrombocytes are then lower than 20, and they can have petechiae, purpura, epistaxis, and very rare they can present with critical bleeding. More often patients are also fatigued and have a lower quality of life. And well, in the case of the immune thrombocytopenia, most often the other cell lines are normal. So there is no leukopenia and no anemia. If we then look for lupus and thrombocytopenia, then usually it's, of course, a secondary immune thrombocytopenia, and then secondary to the lupus. Sometimes it also can be that the thrombocytes are low in the case of microangiopathy. And if you look for numbers, how many patients do have thrombocytopenia, it varies very much, from 7 to 50%. And it's also depending, of course, on what is your definition and when do you call it a thrombocytopenia. Because if you're looking in literature, then sometimes it's even also when the thrombos are between 100 and 150. And then it's around 25 to 50% of patients that do have a little bit, well, lowering of their thrombocytes. But while the severe thrombocytopenia of less than 50 is actually only in 10% of the patients. And if you look to the lupus patients that do have thrombocytopenia, it is more often associated with more severe complications like renal and neurological problems. And it's less often associated with manifestation of the skin and of the joints. And also, and it's a little bit logical, because it's associated with more severe symptoms, but there is a higher mortality in the patients that do have thrombocytopenia versus those lupus patients without thrombocytopenia. So when we're talking about immune thrombocytopenia and SLE, you can sometimes have that a patient has first ITP, and sometimes later, some months or years later, is diagnosed with SLE. So the question is, how often is it a presenting symptom, and is it then together with the diagnosis of SLE, or is it first thrombocytopenia and later on an SLE? Well, and if you look then for the numbers, then well, in around 3 to 16%, there is a concomitant diagnosis of immune thrombocytopenia and SLE. So that it's meaning that the diagnosis of SLE is made, and at that moment also the immune thrombocytopenia was present. But when you have a patient with this diagnosed actually first with primary ITP, so there was no other cause, then in those patients, the risk of developing SLE is 26 times higher than in the control population. And well, it's also different in the different papers, of course, but if you look overall, then 3 to 12% of the primary ITP patients later on developed SLE. And then you can think about risk factors. So which of the primary ITP patients are more prone to develop SLE? And then, well, females are more likely, younger patients. So here is a cutoff of 40 years. If there is organ bleeding, and well, if it's determined, if it's the positive ANA. So if a young female of 32 years, for example, have a primary ITP and also a positive ANA, then the likelihood to develop SLE is rather high. Well, by telling you this also about the definitions of the ITP and the occurrence in SLE, I now want to introduce two patients. The first one is a young female of 20 years old, and she went here to the general practitioner with complaints of fatigue, shortness of breath, and also stiffness of the hands. And the general practitioner took some blood, and it revealed that she had indeed an anemia and also a thrombocytopenia, and the patient was referred to a rheumatologist who examined her very well and diagnosed her with SLE based on hemolytic anemia, the thrombocytopenia of 35, arthritis, and positive ANA, a positive double-stranded DNA, and a decreased C3. And she then was started with hydroxychloroquine, prednisolone, and mycophenolate mofetil. And it went pretty well until 2020, when she was for a control visit at her rheumatologist. And in the blood, there was a recurrence of the thrombocytopenia of 5, and she had no complaints. And well, the question is, and we're going to discuss it later, what is now the diagnosis of this thrombocytopenia, and what should we do with the treatment? And the second patient, again, a young female of 29 years old, a little bit different story, but she went to the general practitioner, especially because of arthralgia, and she was sent to also to a rheumatologist, but well, then they couldn't find a real diagnosis. There was no arthritis at that moment, no other things in the blood, so no rheumatoid factor or anti-CCP, and also the whole she had no anemia or leukopenia or thrombocytopenia. Everything was normal, so she was sent back to the general practitioner with some painkillers and to do exercise. But then, a year later, she again went to the general practitioner, because at that moment she had a cold. Well, that's not that special, but she stayed very tired after that, and she also, and that was the main reason to go to the general practitioner, she had some petechia on her legs. And then blood was taken, and there was an thrombocytopenia and also an anemia, and she was sent to the hospital, and in this case to the hematology ward, because there was a suspicion of TTP-Hus, and Hilde will come back to that later. And she had hematoma also, and the petechia, epistaxis. She developed also fatigue, and she told also about coloring of the fingers. And so she was admitted to the ward, and they did more diagnostics, and the final conclusion was that there was no TTP, but they stated that it was primary immune thrombocytopenia. So again, was this the correct diagnosis, and how should she be treated? But this was only to get you warm and to get you a little bit to wonder what should we do, and hopefully Hilde is going to give us some answers.
Thank you very much, Karina. Thank you, Maarten, for the nice introduction and for the invitation today. So I'll talk first on the differential diagnosis, which should be considered. As Karina already mentioned, we should exclude other diagnoses that can also cause thrombocytopenia before we start to treat the thrombocytopenia as an immune thrombocytopenia. And I think it's most easy to distinguish two settings, the one with a very ill patient who presents on the emergency room, and the other one who's just there for regular checkup at the outpatient clinic, who maybe has chronic thrombocytopenia. So let's focus first on the acute setting. And I think the first diagnosis that was already mentioned by Karina, that should at least be considered. It's not that common. Actually, it's quite rare in the lupus patients, but it has a very high mortality and has good treatment options, is the thrombotic thrombocytopenic purpura, the TTP, which is also generally immune mediated. And the red flags when you should consider a TTP is when patients have fever, if they have neurological complaints, which can be severe, like an ischemic stroke, but can also be much milder and just be some headache. And patients with TTP can have both thrombosis and bleeding at the same time even. So in the lab, you would expect a Coombs negative hemolysis, so destruction of the red blood cells. However, we should not really focus on the Coombs test because many lupus patients already have a positive Coombs in advance. So we can also have a Coombs positive hemolysis and do have a TTP. So what's really helping to distinguish are the fragmentocytes, which we can see in the blood smear. So these are the disrupted red blood cells. And even more specific is the ADAMTS 13, which is a key factor for the TTP. And it's generally below 10% if it concerns a TTP, and the normal value is around 100. So exceptionally rare, but very important to recognize early. Another diagnosis that should be considered and is also quite rare, but has also very important implications is the antiphospholipid syndrome, which can also be catastrophic, and it's characterized by a positive serology, which can be already present before the clinical outcomes and is quite common in the lupus patients. And it presents with typical clinical complications. So it can be obstetric complications in the pregnant woman, and it can be thrombosis, both arterial and venous. And especially if we have both at the same time, then we should be aware of the catastrophic antiphospholipid syndrome. Actually, we diagnosed yesterday somebody with a catastrophic antiphospholipid syndrome. So what's the underlying pathophysiology? For the thrombocytopenia, we know that 1/3 of the patients with an APS do have thrombocytopenia, and probably there are like two mechanisms involved. One is really mimicking the ITP, so it's immune-mediated clearance, and the other explanation is activation of the thrombocytes, which then will aggregate, and it really explains the thrombotic phenotype that's so common and actually a key factor for the antiphospholipid syndrome. For the sake of time, we will mention the other diagnoses that should be considered in the emergency room. So we all know that very ill patients can have intravascular coagulation, but most of the time they have other problems as well at the same moment. So they can have a sepsis, for instance. Patients who just started with heparin, especially if it's unfractionated heparin, can develop a heparin-induced thrombocytopenia. And the pregnant women can have pregnancy-related complications, which develop from the 20th week of pregnancy, like preeclampsia. I think more common we diagnose the thrombocytopenia in the outpatient clinic in patients that are maybe without any symptoms, and it really depends on the type of patient that is sitting in front of you. So Karina was already mentioning young women, and I think the first explanation is less likely in the young women, but comes relevant if patients are older. And it concerns the myelodysplastic syndrome, so it's a bone marrow disease. And what you can see is dysplasia in the blood smear. So I think every patient who has a thrombocytopenia at least deserves a blood smear to see whether there are fragmentocytes, to see whether there's dysplasia. And commonly we also see other cytopenias, but it does not require other cytopenias, but it's a red flag to consider myelodysplastic syndrome. And of course, these patients have sometimes comorbidities, they have co-medication, and we should consider medication as one of the explanations for the thrombocytopenia. And sometimes by just analyzing the timelines, it becomes clear that it's due to medication that the thrombocytopenia has evolved. Okay. But of course, we don't only want to rule out the other diagnoses, but we want to have some supportive data for the ITP. So what we can do is that we check for antibodies against the thrombocytes. It really depends on your cutoff in your lab and in your country how it should be used. We use a cutoff value in which it's very specific. So if you have antibodies, you're already quite sure that it should be ITP. But if you don't find the antibodies, you cannot rule out. But that's something you should discuss with your lab. How is this test used in our lab? What's the negative predictive value and what's the positive predictive value? And another supportive information you can get for lab is the TPO level. So the TPO is the stimulating factor for the megakaryocytes to make new thrombocytes. And it's the opposite from the EPO for the red blood cells. If you have like an anemia, you would expect a high EPO level, erythropoietin. But for the TPO, it binds to the megakaryocytes, it binds to the thrombocytes. So if there are many megakaryocytes, if there's a high turnover of the thrombocytes, you would expect a low TPO level. So here we have a graph. Thank you, Karina. And in the graph, we see that normally if you have low thrombocytes in the ITP patients, you also have a low TPO level. And if you find a high TPO level, you should consider other causes of thrombocytopenia, which can be, for instance, aplastic anemia, which can also coincidence in the lupus patients. And in the older patients, it can be, for instance, hypoplastic myodysplasia. So kind of myelodysplastic syndrome where there are less cells in the bone marrow. For most labs, easy to determine is the immature platelet fraction, which is like the reticulocytes. For the red blood cells, these are the young platelets, and they turn into the blood if there is a high turnover. So a high immature platelet fraction is common in the ITP patients. And when there's doubt, when patients don't react on their or don't respond on their treatment, if there are other signs that there could be an alternative diagnosis involved, you can consider to perform a bone marrow. And if you perform the bone marrow, what you expect in ITP is that the megakaryocytes are normal or increased, so they should not be decreased. So let's assume that we now have an ITP patient. Of course, we all want to know what's happening, and there's a lot of research performed. And I think historically we considered ITP an antibody-mediated disease, which was driven by B cells who could mature to plasma cells, but it was the whole mechanism that we considered. But I think it's becoming more clear that it's quite more complicated. So if we go to the upper left part of the graph, we can see that the megakaryocytes are also involved, that there can be antibodies against the megakaryocytes, so that not only there's a problem with an increased clearance of the thrombocytes, but there is also possibly less production of the thrombocytes. And if we turn downwards, we see the cytotoxic T cells, which can destruct the thrombocytes also by themselves, so which is not antibody mediated. And then on the lower part, we see the B cells, but they are also stimulated by the T cells. So even when there are antibodies, the T cells can still increase the activity of the B cells, and it can be an argument to target the T cells as well. And then we see the thrombocytes who are covered by the antibodies, and they can clear the thrombocytes by the spleen or by the liver, but the antibodies can also influence the thrombocytes themselves. So they can influence the sugar parts, the glycoproteins, which are on the outside of the thrombocytes. And by influencing the glycoproteins, the thrombocytes appear to be older for the Ashwell-Morrow receptor in the liver, and the Ashwell-Morrow receptor will remove those thrombocytes as if they were old. And this kind of clearance is not antibody mediated. So maybe you hope that I just explained a very easy pathophysiology, but I think I'm afraid it's getting more and more complicated. But luckily, if we go to the first line treatment, first we go to the treatment indications and then we go to the first line treatment. I'm a hematologist, so we don't have so much patience, or patiency. We always rush in treatments. But first, we need to consider the treatment indication. So if we have a thrombocytopenia, luckily, we don't need to treat all patients for the thrombocytopenia. Karina already pointed out that it can be more severe patients with worse outcomes, so there can be a reason to treat the lupus, but just for the thrombocytes, we don't need to treat all thrombocytopenias. Actually, we do look at the patients in front of us and we try to consider the bleeding risk, and it depends on age. So we know that children are not bleeding that easily. So most of the time children are not treated unless they are bleeding. We do estimate the bleeding risk, which depends on, of course, co-medication, anticoagulants, but also on vasculitis, lifestyle. If patients have a really active lifestyle, if they do kickboxing, you can consider that as a treatment indication to keep the thrombocytes higher. But for maybe more ill patients, older patients, you should also consider other aspects such as fall risk. But we can try to estimate bleeding risk. But if patients already bleed, we know that we have a treatment indication independent on the thrombocyte number. And in some patients, the thrombocyte number is not really an indication for their bleeding tendency, because these antibodies can also influence the thrombocytes and in this way affect the function of the thrombocytes. But in general, if there are no symptoms in the patients, we do not treat as long as the thrombocytes are above 20 to 30. And our goals are to stop current bleeding, prevent bleeding in the future, but also facilitate an active lifestyle. And what we do want in the future for our patients is that we could be able to increase their energy again, because most of these patients complain of fatigue. Okay, then now we go to the first treatment option, and these are the steroids. And it's not because they have such a nice safety profile. We don't like the steroids for the long term. But what we do like is that these steroids are affecting almost all of the mechanisms that could be involved in the thrombocytopenia, in the immune thrombocytopenia. So to start off with, the corticosteroids are very effective. And in the lupus patients, we consider to start them directly with a steroid sparing agent. And that's different from the normal immune thrombocytopenia, the primary immune thrombocytopenia, because sometimes they only have an acute moment of low thrombocytes. So there we just start with dexamethasone without any other co-treatment. So in the second line, we go back to the pathophysiology. We know all those cells that are involved. And in the second line, in the lupus patient, if the steroids are not working, or if we're not able to taper it well, we could consider rituximab, which is an anti-CD20 treatment and is focusing on the B cells. In the primary immune thrombocytopenia, we should also consider in the second line the TPO agonists, which are stimulating the megakaryocytes to produce more thrombocytes. So then you keep the clearance, but because you make more thrombocytes, the absolute thrombocyte number is increasing. But for the lupus patients who's suffering from all these immune-mediated problems, we think it's not a logical choice to start in the second line already with a TPO agonist. But if you have refractory disease, you can still consider it as well in the lupus patients. So what other options are left after this is not working? Of course, a splenectomy, but we try to avoid that one. So we have the fostamatinib, which is influencing the SYK. It inhibits the SYK, and that's the pathway by which the spleen is removing the thrombocytes from the bloodstream. And another option that is coming, but not still yet available for the regular care, is the daratumumab, which focus on the plasma cells. And of course, it's very logical if you have attacked already the B cells and you still have an antibody problem, that you would then go to attack the plasma cells. And we have from the hematology a lot of experience with the daratumumab, and it's a very mild treatment. So then we go back to Karina, who's going to tell the follow-up on our patients.
Yes, indeed. Thank you, Hilde, for your information and your background, especially also for the treatment, because we're now going back to the patients I introduced earlier. And well, the first one was the young female of 20 years old. And she was diagnosed already with SLE and started then with hydroxychloroquine, prednisolone, and mycophenolate mofetil, because, like you said, Hilde, most often the thrombocytopenia is not the only symptom in SLE. So you're treating, of course, more symptoms and the systemic disease. So, well, by starting that treatment, she went very well, and the prednisolone was reduced to 0. And well, in 2020, she had a recurrence of the thrombocytopenia and no other complaints. So then, like we said, well, what is then the cause of the thrombocytopenia? So then you have to first indeed exclude the other causes, but they were not there. So we thought, well, it is probably again the immune thrombocytopenia, and what was also the case is that her complement levels were also somewhat decreased again. And well, so we decided that it was the ITP with the SLE. And then the next step is indeed the treatment. And well, of course, in a case like this, you first have to be sure that your patient is taking the medication, because she would take, well, we prescribed the hydroxychloroquine and the mycophenolate mofetil, but did she take it? Well, it revealed that she was not, or actually a little. Sometimes she did, sometimes she didn't, and well, maybe 2 to 3 days a week she was taking her pills, but otherwise not. So well, that's of course a problem also for the treatment for chronic disease. So well, we had a discussion, the patient and I, and we decided to start again with hydroxychloroquine in the right dosage. We did not choose for the mycophenolate mofetil because she stopped it also because of complaints of the gastrointestinal tract. So we give her hydroxychloroquine, a short course of prednisolone and rituximab for 2 years with a good effect. And she's now taking her hydroxychloroquine every day, and she's still stable. The other patient was the patient of 29 years old, which was at a hematology ward. And well, like I said, they had diagnosed her with primary ITP because she had no renal problems, no neurological problems. There was a Kooistra biopsy performed, and it was also normal. Her ADAM-TS was also normal. So she diagnosed it as primary ITP, and the anemia was explained by the hematoma, and also a young female and having menstruation. Here I put her course in a timeline because we are having a webinar about lupus and thrombocytopenia, but well, she was first for the rheumatology department in 2023 already with her arthralgia, and now we are talking about a period in the beginning of 2024. And she was started with prednisone, like Hilde said, is the first line of treatment for a primary ITP, and the prednisolone was tapered to 0 and was stopped in the beginning of September of 2024. But unfortunately, she was admitted again in December 2024 with an ischemic cerebral vascular accident. And then at that moment, also the diagnosis of SLE was made, because a lot of exams were performed, and she had, well, on the MRI, a cerebral vasculitis, again the thrombocytopenia, also now the positive ENA double-stranded DNA. Her arthralgia was no arthralgia anymore, but really an arthritis of more than 2 joints. She also told us that she had photosensitivity, and well, there was already a little clue about the coloring of her fingers, but she had also a secondary Raynaud, which was developed in the last 3 years. So that's also a sign that's a secondary Raynaud and can be in the case of an autoimmune disease. So at that moment, we had a very severe ill patient with and the thrombocytopenia in this case is only a minor symptom. So she was treated with cyclophosphamate, prednisolone, and hydroxychloroquine, and later on the cyclophosphamate was switched to the mycophenolate mofetil. And well, everything luckily had a good effect for the patients. She recovered very well, and also the thrombocytopenia disappeared very quickly. So that is everything we wanted to tell you about ITP and SLE. Like I told you, it can be the initial symptoms. Also, months or years before the diagnosed SLE can be made. If there is a thrombocytopenia, think about, is it immune or is it not immune? And if it's immune, is it primary or secondary? Hilde told us a little about pathogenesis, which is indeed getting more complex, but maybe luckily, because then there are more treatment options. And if we look for the SLE, well, thrombocytopenia is often not the only symptom. So by treating the SLE, you often treat also the thrombocytopenia. So thank you for your attention. And this was what we wanted to share with you.
Wonderful. Thank you so much to you both. I think this was a very clear overview on a very complicated subject. And well, I really like the clinical guidance that you gave us on this subject. We do have some questions in the Q&A already. Please feel free to add more. This is your moment to ask your questions to our experts. So I would like to start with the first one by Sunyap Lee. In my practice as a pediatric rheumatologist, there is a handful of children with ITP with ENA positive, but no other signs of lupus, including normal complement. Surprisingly, quite a number of them have double or triple positive antiphospholipid antibodies, but are asymptomatic. Anyone has any experience in these cases and any role of genetic studies? Good question. Who wants to elaborate on this?
Yeah, a very good question. But I'm sorry, I do not have experience in that or genetic testing. Indeed, it's often also associated with antiphospholipid antibodies, so that's also an association. And of course, in children, you also have to, or quicker, so to say, think about a genetic problem. So, but I don't have the experience or what is linked to that. I'm sorry.
No, I think these are two ways that there is expression of immune dysregulation. So it's not a coincidence that they happen and they appear together. And I think Karina has a bunch of patients who are having not a lupus yet, but have several signs that it can develop in the future. And I think that would apply for these children as well. But Karina is the expert. So what do you think? Are they at risk to develop a systemic disease in the future?
Yes, I think so. Yeah, it is indeed the first sign already of immune dysregulation, and at such a young age. So yeah, and maybe we know, of course, about the interferon pathway, and also that's an important pathway. And well, if it's really monogenetic, I don't I don't know. It can be in some of those children, but in a lot of children, I think it's also and not a monogenetic, more a genetic risk, so to say. Yeah.
I think as Hilde illustrates, I think of course we are all not pediatricians, but in the adult population, I think we do recognize this phenotype as well, with at least thrombocytopenia, positive ANA and antiphospholipid antibodies without thrombosis and without other signs and symptoms. And we either classify them as incomplete lupus or incomplete APS, I think depending on who sees the patient first. So I do think we recognize the phenotype. And yeah, I'm also not sure about the genetic part, at least in adults, that is not a thing we look for. All right, thank you for that. Let me see, then there is a question whether in ITP patients also CNS symptoms can be observed, maybe related to local vasculopathy. Is this something you come across?
I think we do wonder why these patients are tired all the time. I think that could be considered a CNS symptom as well, maybe. So maybe there is some interference with the cytokines which are released. And I think future treatments are really focusing on not only treating the thrombocytopenia, but also to see whether you can really downregulate the immune dysregulation. One of the treatment options that are coming are probably the BTK inhibitors, which can also really regulate this very downstream. So normally in the ITP patients, we do not have the TMA. So if there are clear neurological problems, if they're like ischemic stroke or something, we do know that the ITP patients are at increased risk for thrombosis, but it's not a typical symptom. So I think in that case, you should consider the antiphospholipid syndrome, you should consider the TTP.
Yeah, very clear. Another question in the chat, do we need to consider platelet aggregation as a cause of thrombocytopenia? How frequent would that be?
Yeah, so I think the intravascular coagulation, the DIS or DIC, I think that is a way of increased aggregation, increased activity, and also thrombotic phenotype. So, but you would only expect this phenomenon in patients who are ill, who present on the emergency room. So I would not consider it a regular explanation for low thrombocytes at the outpatient clinic.
Mm-hmm. And maybe here more the more laboratory part is meant with thrombocyte aggregates that are found after taking the blood, but that are not circulating in the patient, and that's why we test in citrate as well. Is that something?
Yeah, but we do not have it does not have clinical implications. So we do not consider it as a problem that should be solved or something. So I don't think there is clinical information in it.
All right. Another question in the chat, and that's a good one. In ITP and APS combined, do you treat just with anticoagulants? And what is the risk for bleeding then? How do you cover this?
Karina, do you want to answer it?
Yeah, so if I understand well, it's a patient with thrombocytopenia and also APS.
Yes.
Or,
yes.
Yeah. You always have to balance, of course, but if you look for the cups, for example, we of course also use the immune suppressive because there is an immune activation and it's also causing well, the severe symptoms. So if there is an ITP and also a thrombosis, yeah, then you should do both, but then waiting of balancing between the bleeding risk, of course. So you have to, if you give heparin or low molecular heparin, then you should adapt the dose, of course. So yeah.
But it really depends on the phenotype. So if it's just a new thrombosis and you don't have bleeding complications, you would consider anticoagulants as much as possible because you know they otherwise will develop extra thrombotic events. But if you have like a thrombotic event years before and the patient is still on anticoagulants and there's a new immune thrombocytopenia, maybe you can lower the anticoagulant dose much more easy. So it really depends on the phenotype at that moment, I think.
Yeah, and maybe to put it a bit further, are you worried about APS patients with thrombocytopenia that do need TPO agonists? Is it like creating more prothrombotic state by reestablishing a kind of normal thrombocyte count?
Yeah, so we had real attention for it during the normal ITP studies with the TPO agonists, and we couldn't make it very clear that it was there. But I think in clinical practice, it seems that these patients do have a higher thrombotic risk. So patients with a thrombotic phenotype are not the excellent patients for the TPO agonist if you do have alternative treatment options.
Yeah.
There are some ways that the clots will also become more firm, is the thought, by the TPO agonist. So not only a more active thrombocyte production, but also other kind of clots.
Yeah. Okay, and then maybe one final question about infection and thrombocytopenia, because there are infections who can also cause thrombocytopenia. And would the treatment of those infections eventually solve the thrombocytopenia? So maybe in other words, are you always in a new thrombocytic patient? Are you always screening for viral infections? And if so, are you sure you can wait until the infection resolves or just treat the infection and not treat the thrombocytopenia itself?
Do you want to answer, Tina, or shall I answer?
No, Hilde, it's yours.
So infections do cause or can cause thrombocytopenia in several ways. So they can activate the immune system. So if there is a low activity already, they can worsen it. But like viral infections, they can also influence the glycoproteins on the thrombocytes. Like I explained, they will assume older for the liver, and they will be cleared much more faster. And you do expect that this will resolve after the infection has been treated. However, sometimes it's just the trigger for ITP to become clear, but there's already ITP action or activity before. So not all of these patients will go back to normal thrombocytes, I think, but it's not caused by the virus, but it has become clear because of the virus. And we do this see the same effect with patients who are vaccinated. They can have a lower thrombocyte count, but most of the time, if it's due to vaccination, they will come back to their normal values as they had before.
Right. Wonderful. So with that, I think we have to quit. I think we can discuss way longer, but our time is up. So I would really like to thank you both, Hilde and Karina, for a wonderful presentation and your very clear answers on all the questions. I would like to thank the organizers, the ERN Reconnect, for making this possible, and of course all the attendees who were here. And I hope to see you back at the next webinar. Have a good afternoon and a safe summer. Bye-bye.